I want to start with a congratulation to all of you for allowing Margo and myself to be here, but also for organizing an event like this. It feels very welcoming, feels very safe, feels very warm. I also want to say that 2024 does feel different, not necessarily in a helpful way. And we're also trying to find the balance between joy, because we need to stay with joy as much as we can, but at the same time also realizing that I think Pride 24 has never in the last couple of years been as politically relevant as it is this year. And I see a few of you nodding with depth. So what we're discussing today, Margo and I will be discussing, really goes for us beyond just showing you fancy gamification. But it is a way of us having thought quite deeply about how can we make the things that matter to us and the inclusivity that we think should be the norm accessible in a way that is meaningful and interesting to healthcare providers and researchers in the cancer space. I do want to acknowledge your funding or your donation work. I've donated, so I've done it. You all can do it too. So think about it, please, and donate as much as is appropriate in your situation. I just came back from Uganda, which most of you know is a very, very tricky place, probably one of the trickiest places to be in at the moment as a queer person. And I don't know whether you're all aware, it relates back to cancer care. The HIV clinics in Uganda have over the last 12 months seen a decline of 80% of attendance. Now, that is immediately just antiretroviral treatment therapy. But you can see how very quickly that actually switches over to cancer care as well. Because if you have untreated HIV, you will eventually end up with cancer diagnoses. The reason for why people don't attend anymore is because they are being targeted, including those who are housing people of queer communities. So if you're housing someone in Uganda who is identified as queer, you can go to jail for up to 20 years. The situation is dire in other countries around the world as well, and certainly not ideal in Canada either, but I do believe that us standing here together with you, having the opportunity to just openly talk is an enormous privilege and a value that we like to take advantage of, but also defend. So on this somber note, and I promise we're going to get much more lighthearted, I wanted to start us off because what we started about 4 years ago now was over a very heartfelt conversation about how things had not gone so well at UHN for a while. And now we see that things are changing. How do we do this and how did we go about it? That's what we want to discuss with you today. So the slideshow changer is different. And we got a lovely land acknowledgement already.
Thank you so much for that.
Thank you. It was beautiful. Is there anything you want to add to it, Margo?
No, it was beautiful. And I was going to speak a little bit about, June being such an important month for Indigenous history. And it's so lovely that we can sort of share our Pride Month and Indigenous months together. So we thought we'd just start by giving you a very sort of quick overview of the program. So what we've been up to over the past 4 years, as Christian mentioned, is looking at some ways that we can develop some tailored information to look at some ideas around support groups and resources, specifically for our SGDc patients. Maybe I should just back up a little bit. So we use the term sexual and gender diversity, so SGD, and we're inspired by that term that was being used at a lot of diversity centers in different universities. And it's certainly a little bit easier to say than to us LGBTQIA+. SGDC kind of rolls off the tongue a little bit easier. The other term in research that we see quite a bit is sexual and gender minority, so SGM, But we really felt it was important to emphasize the diversity that's, very reflective of our very vibrant communities. So that's where that came from. So sort of back to our little slide here. We've also done sort of a lot of work on our EPR system, and including some inclusive questions that patients can go into their MyChart and complete some information about the name which they wish to be addressed by, their pronouns, their sexual orientation, and gender identity, if that feels comfortable for them to share with the team. Some of the patients have been really excited to be able to do that and have expressed that it takes a little bit of pressure off, needing to come out to every single one of the million healthcare providers they encounter, at a visit. We've also been really involved in a lot of collaborations. We have a beautiful partner, Queering Cancer, who started the work before we did. And it's been really lovely to be able to work together with them. Over the past year and a half, we've been working really hard at developing a needs assessment, and we completed 21 interviews with our patients. And we're just in the process now of finishing analyzing the data and hopefully sort of wrapping things up. And it's been really inspiring, the things that we've learned and some of the really beautiful quotes that patients have shared with us.
Yes, so very quickly, just to introduce here clearly that it's not just the two of us doing this work, but a large group of people. We wanted to introduce our team. The names are all on the right-hand side. I'm not going to go through everyone. What I want to emphasize is we're an interprofessional and interdisciplinary group of people, and all but one of them are working pro bono in this field in our program. So the only person who is actually funded by Princess Margaret at the moment is Margo, who has, and we are very grateful for it, 0.5 full-time equivalent as a social worker and the clinical lead in the program. And all the rest comes from us, from people who do the work after working hours, and often also on the weekend to bring this topic forward. And it's been amazing to see how it has evolved over the last 3 years.
Such a collaborative endeavor.
But we are very happy about the mother of the house, Margo Kennedy. So very quickly, so important to ground ourselves in what we think is important for this work. Social justice, IDEAA. The acronym is used in different configurations. You all know what we're talking about, but social justice is kind of the underlying value that we're following. And we've decided that the 4 pillars that we try to base our work on the most are pronouns, gender identity, sexual orientation, and relationship diversity in the context of cancer care. All not surprising. I just wanted to make this clear on this one slide that these are the main foci of our work. There is much, much more that could be done. We could be talking about housing. We could be talking about accessibility in general, but these are the 4 topics we started to focus on and feel that we're moving the needle at the moment.
Yeah, I think those are 4 really key domains that hopefully give people the basics in providing culturally competent care to patients and chosen families.
So before we go here into more detail, I want to say we started our work with you today talking about avatars, and you're seeing here our first avatar, Bo. Bo is a development over the last year, which is a extension and much more complexer than what was in the education space already before. You might have heard about the genderbread, or you might have heard about the unicorn that is sometimes used. And there were some problems with these kind of models. And so we sat down and wanted to develop something that is specific to cancer care, to explain to many people, probably not to you here in the room so much, but to many healthcare providers, what we're actually referring to and why it is important to understand the difference, for example, between gender identity and gender expression, or the difference between pronouns and sexual orientation, or the difference between sex and relationship. So we're going to do this with you very shortly, but what we're going to focus on in this first part of our talk is we're going to introduce Bo and talk a little bit about how this is relevant to cancer care and why it might be relevant for you as researchers and scientists in this field. Make sense? Let's do it. Margo, over to you.
Right. So Bo is a tool that's now available on our SGDc website. People can download it, and it's a series of slides that sort of go through these different very important aspects that relate to patient care and people's cancer experiences. So the first thing we like to remind people about is that folks aren't just all about their sexual orientation or gender identity, nor are they all about their cancer diagnosis or tumor. That people bring all parts of themselves into the hospital, into their care. And some of these aspects of people's identities, which might include their race, their ethnicity, their mental health status, all kinds of things, all play a really key role in giving people maybe some advantage or privileges, or also some disadvantages in some scenarios and some invisibility. So we really feel it's important that we sort of look at people sort of as a whole and really be able to understand and connect with and have a dialogue with our patient communities around how this all works to affect their experience.
Now, I want to flex something here that's very important to us. Very quickly, a talk about equity-seeking groups in general can feel like a talk that is prescriptive about what you are allowed to say once you leave the room and you have learned. And we struggle with this as we're trying to educate, even now as we're talking to you. What we're not trying to achieve, but sometimes inadvertently achieve, is a sense of, that's the only one right way to do. All the super egos are activated and we are going to monitor you. And if you get it wrong, you're bad. And that creates a sense of silence and awkwardness in many healthcare providers who otherwise actually, as we know from our own research, have a true, genuine interest in learning more and understanding more, but feel very, very insecure and sometimes inept even in their own words in how to address those different communication elements. So in everything we're saying now going forward in this talk, and you will see it later on in our actual interaction online in our e-learning program, we're not focusing on saying the right thing at every moment in time. We're very much focused in our education approach around authenticity and getting it wrong in the right way. So how to apologize in the right way when you get wrong the pronouns, when you're not aware about sexual orientation, you're misgendering or mislabeling someone, or you're not realizing that this relationship, a throuple that you are in front of is not a friend and someone else, but actually the chosen family of a person. So we're very much focusing in our initiative to be imperfect in the right way. So we invite you very much to feel that as well. And as you're following the talk, to maybe notice what is making you more anxious and nervous and what is more enjoyable about what we're talking about.
And we come to this very humbly, and our whole committee, that we very much, learn from each other and, really take a great deal of interest in people's different opinions and experiences and being able to talk that through.
Which is not always easy.
No, absolutely.
Sometimes it's difficult, and sometimes it is not always resolvable right away. But so far, we've always been able to find a way to navigate it. I think the worst solution is the solution of silence and of silencing. And so we want to motivate you to please speak up and be with us today, even when you have a question where you think, oh my God, can I even allow myself to know that I think this question? So if you do think that question, bring it up and be with us here in hopefully as safe a space as possible, because only then can we actually change culture. So over to you, Margo, the cancer pathway.
All right. So Bo is kind of short form for our little person here. Rainbow is where their name came from. And one of the important things that Bo wants to convey is that connection between SGDc and the small c part, the cancer. Like, what does this have to do with cancer care? And we've noticed that, I think, based on our training, I can speak personally. I never learned this in social work school. I think this is a fairly new area. And, most of us haven't had that sort of education to be able to sort of make those connections and links to, how this really relates in a very, very real way to cancer care. So that's a little diagram of the sort of cancer care pathway. So one of the things we encourage sort of people to think about, and this is from maybe a very patient-centered perspective, is what exactly are those questions that make experiences a little bit different when folks walk through the doors at Princess Margaret? So it can be all kinds of questions about, what if I experience homophobia or transphobia or biphobia? What should I say? I don't, I've got a lot at stake here. I don't want to make any healthcare providers mad at me. Will there be an all gender washroom available? Going to be filled with fluids from chemotherapy. I hope I won't have to, be faced with a male or a men's or women's bathroom to choose between. Will my chosen family be included? Will the people write in my health records that I'm queer? And am I okay with everybody sort of knowing that? Who has access to these records? What if my parents see that? Should I come out to my providers? How will this interact with hormone replacement therapy or PrEP? Am I going to be the only queer person in the support group? There's many, many issues and questions that I think are really important for us as healthcare providers to consider.
So let us talk about gender identity as a starting point. And again, the majority of you have a lot of knowledge about this already. We're going to keep it cursory, but we want to apply it to cancer care in particular. So it's from our perspective and how we define it, and that's why we're also putting it up here in the whole shadow of the person of Bo. It is the identity, it's the person's internal sense of self and how they identify themselves. So it's an internal aspect of seeing yourself. That is our position, socially constructed. And because it is so, it also comes along with expectations and comes along with how we all collectively understand what it means when I say man, woman, male, female, or anything else in the more non-binary or trans or even questioning experience. So we've tried to find the right kind of colors, and it took us a long time to settle on something. We want to hear your feedback, whether this color scheme somehow makes sense to you or not. We had all sorts of colors. We were very, very out there, and then thought, no, that's too much. And then it was a little bit too little. Everything got very gray. And so now we kind of stuck with the, it's not an unconscious bias. It's a very conscious decision with a blue for man. We didn't want to do a red for a woman, but something in between. And then we also have the dimensionality of multi-gender, non-binary, and agender on this spectrum here. Gender fluidity being in the middle. And I think that this is a very good, one glance depiction of how one can, on a very basic level, understand gender identity. If any one of you has feedback, please share it with us.
I just wanted to add the dotted lines inside of Bo's little figure sort of are representing how this is sort of your inside part of yourself and how you identify. So in terms of an experience of how this relates to cancer care, this is a patient, Matthew, who's non-binary and feels so much stress before each of their clinic appointments and dreads having to come out to multiple healthcare providers after experiencing discrimination at another healthcare institution. They feel emotionally exhausted when they're asked if they're a trans man or are you a trans woman? I think it gets tiring for patients sometimes when they're already dealing with cancer and so much to have to take on that responsibility of educating their healthcare providers. Becomes a bit draining.
So in our work, we've identified that especially in cancer care, where we have situations where people sometimes need to adapt and adopt to what cancer care is doing with them without their choice. That the difference between gender identity and gender expression becomes extremely important to understand and recognize. Gender expression, from our perspective and how we try to teach it, refers to how a person expresses the very gender identity we discussed before through appearance, clothing, behavior, and might I add, interpersonal interaction. And this does not necessarily mean that there is a congruency between gender identity and gender expression. Someone who has a certain self-identification as an internal sense of gender and meanness does not necessarily need to present in the way they express their gender as masc or femme or androgynous or gender fluid. So that's very important for us to bring up. And also it is important to bring this up because, as I say, cancer treatment over at Princess Margaret, especially in the inpatient unit, especially on our palliative care unit, when we're coming to the end of life, can really be very significantly different from how the person identifies in their gender. And this can create a whole lot of enormous suffering. Having to hold for the chosen family of those who no longer express and present in the way that they identify.
So an example of gender expression is, through this next little story. This is Czar, a trans man who experiences gender dysphoria and anxiety after losing facial hair or their beard following chemotherapy treatment. He feels devastated by being misgendered in different places on numerous occasions without his beard.
So we're using the term gender dysphoria here intentionally, and we know it can be a trigger for some people, but note that we're not using it for a medical diagnosis, but we're using it in the paradoxical mirror idea of it, where someone is dysphoric about their gender experience because of the treatment that they're undergoing and the lack of control of what is happening to them. So the true actual idea of gender dysphoria as such. Yeah, pronouns, it almost feels like it's too 2018 to even talk about it. But then again, I don't see pronoun buttons on all of you, only on some. The pronouns are extremely important. We also don't talk about preferred pronouns anymore, because if they were preferred, then they wouldn't be what people would like to be addressed by. And so we just say pronouns. There are the single pronouns, mixed pronouns, neopronouns, and people who have no pronouns. And it's also very important to please keep in mind in our multicultural and multilingual country that we live in, that not in every language the idea of pronouns actually works well. Which is important to keep in mind when educating healthcare providers, because if you have healthcare providers in the room who speak a second, third, or fourth language of English, and you're trying to educate, it's so important to keep in mind that not everyone necessarily intuitively grasps the idea of a pronoun, because their mother tongue might not have pronouns or gender-specific language in the first place. Can I ask, is there anyone in the room at the moment whose mother tongue does not have genders? Thank you very much. So you understand what I'm talking about, which doesn't mean you don't grasp the idea of pronouns, but it might be helpful for an educator or someone who talks about the topic to have sensitivity towards the understanding that you two have to go an extra step, right? Which makes it a bit more complicated. And again, going back to what I said earlier, invites much more also being open about this and saying, you know, pronouns is a tricky thing for me. So if I get it wrong, please call me out on it, but please, please also have some gracious kindness. Okay.
We encourage our healthcare team when they introduce themselves to patients to also include their pronouns, so I would say, hi, I'm Margo, I'm one of the social workers. My pronouns are she, her. How would you like me to address you? And even though there has been moments where it's a little bit awkward or uncomfortable, you know, maybe with an elderly patient who says pronouns, what's that? It's still important, I believe, for us to be able to do that. And a beautiful quote from a patient in talking about the meaning of wearing a lanyard and a pronoun button was she spoke about how she taught her children that if they needed help to look for an adult with a stroller. And she said that's just how she understands pronoun buttons and rainbow lanyards, that if she felt she needed help from someone, a safe person wearing a button or a lanyard would maybe be the person she'd look for. So I think that's really significant of how much meaning some of these very small things can have. So Emerald uses they, them pronouns, and it has had to repeatedly, over and over again, advocate to have her notes changed to include their correct pronouns. They feel frustrated, humiliated, angry, and disappointed by not being heard and having to discuss this over and over and over again. They're losing trust with their healthcare providers and recognize that this is a microaggression.
So again, want to emphasize the point that not getting pronouns right per se is not a microaggression, but if you try to bring it up and discuss it with your healthcare provider or research team over and over again, and you feel all you get is a smirk and silence, then that is actually, I would argue, no longer a microaggression, it's an overt aggression, but you get my point. Now I'm going to talk about this one because this is the one where we then sometimes get a little bit awkward ourselves and say, well, but actually there is something that is very biological and very relevant, and unfortunately nothing we can choose. Our genetic, biological sex determinators. And why is this relevant specifically here in this group? Well, because we know in medicine and in research that some of our treatments and the approach to treatments and also the way we dose our treatments are dependent on the chromosomal genetic level of the person in treatment question before us. So anatomy is important, chromosomes and hormones are important. And this can sometimes be a slightly difficult conversation when you're trying to be very inclusive and to respect a person's gender identity, pronouns, gender expression, and doing a good job, but then needing to talk openly about the underlying biological disposition because it influences the treatment plan. So we do not want to ignore the fact that it is relevant. And we also, of course, want to acknowledge that there are friends among us in the community who are, from a biological perspective, on the intersex spectrum, and therefore have a very individual situation, which can, again, be completely different from their gender identity and their gender expression.
So an example is Zane, who's 60 years old, recently diagnosed with advanced metastatic prostate cancer. Zane was assigned male at birth and then diagnosed as intersex at puberty. Zane uses the pronouns they, them. They want to enroll in a clinical trial, but were informed that they may not be accepted due to their intersex status.
So this is where we reach out to you as researchers or representing researchers, and very much hope that the current discourse that is accelerating, we can see it everywhere, about being more inclusive in our research trials is very important to follow and to participate in. Of course, and that's a very basic, simple problem that we had when we had our first coffee together 4 years ago. The biggest issue is if you don't even talk about the topic and create the database, if you don't have the data, then you can't know what actually is going on and you will not be able to advocate. So creating some kind of system that will at least capture some of the identifiers that we are discussing with you today would be extremely important as the first step before we do any grandiose attempts to integrate more diverse populations, because we can integrate more diverse populations, but if we're then not keeping the data, then we have nothing to work with. Sexual orientation, do you want to say anything?
You want to go ahead and do that?
Sure, yeah. So I'm not going to talk much about sexual orientation because most of you will have some tentative idea of what we are talking about. What I do want to say is that it is relevant because it's often used at the starting point from a feminist or deconstructive or queer theory perspective to say that most of our thinking, even the way we're, for example, sitting in the room right now and us talking here, standing here, and you looking at us and the audience, it's all coming from a very heteronormative practice and history. And so heterosexual on the left-hand side is not meant to be a negative label, but it is important to say that heterosexual and heteronormative behavior in society is where most of our interactions in society are built on. And if we take any kind of interaction, we can deconstruct it in that sense, and then we can also start deconstructing that most often in a large part of the world, they're based on cis white heteronormativity, which is not bad. There's nothing wrong with it per se. It's important to be aware of the fact that it is so, and that with it comes along a power dynamic and a power discourse that if we want to have an open, really honest conversation, will make some people feel a bit fragile. Often not those who are not the owners of the privileges, but those who are the owners of the privileges. And I think we're starting to have this conversation more helpfully. The other side of it is minority stress. It's that which most people live with without naming it, actually, that permanent sense of something could happen, and very quickly being sensitized towards being discriminated because of a certain identifier, although it might not in every case actually be the case. So I'll give you an example. So Leah is a young mixed-race bisexual woman with cervical cancer. She has been experiencing isolation and has a number of questions regarding sex and intimacy after her cancer treatment. She is unable to find any support groups or resources that can meet her needs. She feels very alone in this experience, not understood, and that she doesn't quite fit or belong anywhere. Relationship diversity. Do you want me to go on?
Sure.
Yeah.
Great.
Yeah, we have our favorite topics. So relationship diversity. I actually know, Margo, when I first introduced this as the fourth pillar, there was some resistance, right?
Yeah, I thought, oh, my mother would just not want to go. That's going too far.
Yeah, exactly. Yeah. Let's be
Yeah.
inclusive, but not too much.
Yeah.
Well, but we had a good conversation about this because it actually really has a lot to do with the realities we live in. And don't get me wrong, I'm not just talking, mother of house and New York style in the 70s kind of chosen eclectic families. I'm really also talking about the epidemic of existential loneliness that many of our queer folks are experiencing. And so when they come into cancer care, into the system, very often they're by themselves. And then often we have to ask the question, who can you have by your side? Who will tonight, after this difficult news, be there to give you a hug? Unfortunately, not for everyone, but for not few people, the answer is nobody. And so when we talk about relationship diversity, we're also talking about it from the perspective of unpartnered, alone, single, 70s, no longer partying or whatever my unconscious bias might be, but alone. And so this is something that we need to address as well. Sometimes starting cancer care, the question comes up, for what? For whom? Why? One partner is what the majority of us are living, monogamous or not. Majority of people say they're monogamous. Psychotherapists know that that is not always the case. Having multiple partners, what we also call consensual non-monogamy, or the older term polyamory, is referring to the willingness to bring a conversation about having multiple partners into the open, into the discourse between partners. CNM, so consensual non-monogamy, does not necessarily just mean I am having sex or intercourse with several partners. It can have all sorts of configurations, and in the queer community can take the form of 4 or 5 people living together as a housing community, and there is no intimacy happening at all. It can also mean that I have a core or a nesting relationship with one person, and I have several satellite partners who are fulfilling clearly delineated and boundaried needs that are consensually clarified between all partners involved. Can take amazing forms and certainly is not an easy field, has a lot of complexities, but one thing is for certain, and I don't want to be the downer all the time, but if someone gets difficult news, or if someone is in the situation of really now facing the end of their life, we don't want to exclude these people. We want everyone to feel that they can bring in and have by their bedside who they need. And that can be more than just one person.
I think there's a lot of stigma around this topic. And I think many patients are reluctant to sort of bring that to healthcare providers' attention out of fear of judgments.
Yeah. And sometimes also just simple lack of knowledge of life experience, you know? Some people, it's so sad. I heard some people turn 80 and never had another partner in their life. That one didn't land, okay. So give an example. John was urgently admitted to the inpatient department for an adverse event secondary to her cancer treatment, and she is in a poly relationship with 2 partners. Her healthcare team has told her she has to choose only one partner to receive updates regarding her clinical status. She feels disrespected and that her relationship is being discounted and invest. I want to make the point again from an education perspective, relationships do not all need to be intercourse oriented. They can also be platonic, and that can be just as meaningful and existentially powerful.
Can I just add a quick thing?
Please.
We just want to give a special shout out to one of our team members for her beautiful artwork and graphic design, who hand drew all of these images. And that's, I'm trying to think of Emily's last name.
Yes, Emily.
Lovely Emily. And Aaron and Sam, worked really hard. Emily Taylor, thank you. And she works with the patient education department. So we're so indebted to her talents to sort of bring forward, some of these ideas. Yeah.
Okay. So in the second part of our presentation, it's just about 5 more minutes, so we will have time for Q&A. And I just wanted to let you know that we're also trying to be good enough clinical researchers, applied researchers. So we went into the literature and did a top-down approach to also find out what's already out there when we started our project 3 years ago. We did so because we wanted to make sure we're not just repeating the same thing and reinventing the wheel over and over again. We did notice one thing. There are actually also cool things in the queer community in the sense that they're actually better off than others. So for example, one example where we found a really good article that compared the psychosocial support system for breast cancer survivors in lesbian couples and non-lesbian couples. And alas, the lesbian couples had much better support and also a higher quality of life because the kind of support that is needed after breast cancer seems to be very much embedded intuitively in how lesbian couples interact with each other. So salutogenic factors identified, so positive factors identified in queer communities, something we didn't want to miss mentioning because it's not everything is said and everything needs to change. We also did a bottom-up approach, making sure that in Princess Margaret on the other side of the street, we are understanding that what we find internationally in the research literature does also mirror back to what people need locally. And we did this poster. You don't need to read the details of it. I just want to get your attention to 2 aspects. Margo is going to talk about the what does inclusive care look like aspect. And I want to quickly draw your attention to the upper right corner, the drama of the queer child, which is a little sneaky adaptation from a psychoanalytic theory from way back then. There is a dynamic that our patients describe where because of their queer positionality, they are trying to make the healthcare provider feel very good about themselves very early in the interaction so to make sure that there will not be any type of conflict. And this extra layer of burden, of intersectional pressure to remain on the good side of things with healthcare providers is something that is a very specific phenomenon to the queer community. Obviously to others as well, but we found it in the queer community clearly articulated in our interviews. A little bit more, Margo, on the inclusive care, because that was a surprising finding for us as well.
Yes, so in our qualitative interviews, we ask patients, so what would inclusive care look like to you? And patients really struggled to articulate that. And what we came to see, so I keep on forgetting to move for the camera. And what we came to realize was that this isn't something anyone's really been asked before, really considered. So it's almost like standing outside a buffet and looking in the window and someone asking, what would you like to eat? But you don't know because you can't quite see the food on the table. You don't know what the offerings are. And this is very new. An experience that came to my attention just last week, actually, was thinking about a patient who worked so hard on getting all of their ID changed and then their first name changed on their health card. And they came into a clinic appointment and told the admin person at the desk, oh, I have a new health card and my new name is finally on my health card. And big smile, all excited. And the admin assistant, took the health card and was very busy on the computer for quite some time. And then I handed them a bracelet, which had their incorrect name, their old name on it. And so the patient handed it back and said, oh, this isn't my correct name. Can you fix it? And the admin person had a really hard time, got other people over to help, and they eventually got it resolved. And they put their bracelet on. And we're very appreciative of the extra effort to have their correct name on their bracelet. The next week, they went to their family doctor. Same thing. Here's my health card, my new name. And the family doctor reception gave them a great big smile and said, congratulations. So I think that tells us subtly what inclusive care looks like.
I want to jump to the final point. All of this is interesting, but also a bit didactic. And so we wanted to give you an opportunity to see how we have tried to make it a bit more interactive. We have a new platform. It's called pmchosenfamily.ca. I will send you a QR code for it in just a second. And this platform actually relates to how you can train yourself to communicate with avatars. Yes. So some of you will have received already our lanyard.
They're around the table.
It's a table. You can scan it. You can scan it here from the screen. If you have a mobile phone with you, please do it now. If you don't have a mobile phone with you, little joke, then you can also do it later. Please give this a try and check it out. We are quite happy. We have launched this with our cancer education folks about 3 weeks ago. And this is a project where we're introducing you to 4 avatars, Chetan, Lexi, Max, and Ross, who all have their own story going through cancer care. And you have an opportunity to engage with them in a more inclusive or less inclusive way, and you'll find out what happens. You can educate yourself on pronouns, sexual orientation, gender identity, and relationship diversity. And for those of you who are a little bit more geeky, just for the background, how did we do it? Because it was before AI took over the world. We did hand program it all. And that means that we needed to reduce the possible options available, because otherwise it would have had mushroomed and 1,000 different dialogue possibilities. So the way we did it was that we created one conversation topic and then 4 different ways of how you can respond to this with a certain reaction. And then it would, in any case, always lead over to the next topic. However, if you got the patient angry with a rude response twice in a row, the patient will terminate the conversation and leave the room and stop talking to you.
You get fired.
Yeah, you get fired. Exactly. However, going back to the initial point that I had made, if you are rude only once and you know how to say I'm sorry, afterwards, the patient goes back to a level where they stay in the room with you. So there is interactivity and responsiveness to your behavior within the chosen family environment. This is how it looks like. You can see it all on your phone. And it is also platform independent. So whatever device you use, you will be able to see our product. Okay, so I think we'll leave it at this because we do want to make sure that you have time to say things to us, about us, or with us. These are all the people that were involved in creating our e-learning environment, PM Chosen Family CA. Some of you have already signed up for our upcoming Pride 24 event. Just want to remind you, in 22, this was our very first time we marched. We were exactly this amount of people, 13 or 14. Last year, already with your participation, we reached about 50 people. And this year we have anticipated around 200 participants from UHN. Thank you for your attention, and the floor is all yours. Happy Pride.